Hello, and thanks for joining us today for this ALZpath webinar. My name is Matías Jauregui, and I will be your moderator today. In this webinar, we are super excited to introduce Dr. Henrik Zetterberg, Professor of Neurochemistry at the University of Gothenburg, Sweden, which will present a talk titled Plasma Phosphorylated Tau from Method Comparison to Cohort Studies and Remote Testing, and also to introduce Dr. Kai Blinov, Professor of Clinical Neurochemistry at the University of Gothenburg, Sweden, which will present a talk titled The Path to Clinical Implementation of Plasma Phosphorylated Tau 217. During the presentations, if you have any questions, you can submit them using the Q&A button, please, at the bottom of your screen. Please put your questions here and not in the chat window, so we can be sure to record your questions to answer during the Q&A session following the presentations. Also, we are recording this webinar, so if you miss any part of it, or if you want to rewatch it or share with your colleague, you will be notified in a few days by email, where you will have a link that you can access the recording of the webinar. So without further delay, I will turn the time over to Dr. Zetterberg.
Thank you very much, Matthias, and thanks to ALZpath for allowing me to speak in this symposium. I am very happy to be here, and I will start by sharing my screen here. There we go. So I was asked to talk a little bit about plasma phosphorylated tau from method comparison studies to cohort studies and remote testing. And I will, since this is about Alzheimer's diagnostics, I wanted to start with amyloid, of course. So amyloid plaque pathology is the defining feature of Alzheimer's disease. And then one could think that it would be reasonable to measure a plasma amyloid beta biomarker if one wants a blood test for Alzheimer's disease. CSF A beta 42:40 ratio, the 42 amino acid long form divided by the 40 amino acid long form, is a very good and FDA approved fluid biomarker for amyloid pathology. It works quite well. This is what it looks like in CSF, a strong reduction in amyloid PET positive people who have amyloid plaques in the brain, compared with negative people who are not having these plaques. And this reduction is around 50% actually. These people tend to move from being amyloid PET negative to becoming amyloid PET positive if you follow them over time. These peptides are possible to measure in blood, but there you see that the difference is much smaller and the overlap is larger, and the percentage decrease here is only 10-15%. So it's a little bit of a more difficult biomarker to run in clinical chemistry practice, basically. You have to have very tight control on your assay, not to mislabel people because of any variation or assay drift. And this is another way of looking at it. This is what the populations look like if you plot plasma A beta 42:40 ratios and divide the people into amyloid positive and negative. You see that these two populations are very, very close to each other. So it's a difficult biomarker in blood. This graph illustrates this further. So in red you see amyloid PET positive people, and they are having a different ratio than amyloid PET negative people as a group, but there is no wiggle room for the assay. And there are also some medications and some other confounders that can affect the ratio, which makes it a little bit of a difficult biomarker. If you look instead in the CSF A beta 42:40 ratio, you see that there is a clear distinction between amyloid PET positive and negative groups, with some wiggle room for assay variation and drift. So it works much better in CSF than in blood. The explanation is that there are A beta peptides released from non-cerebral peripheral tissues like blood platelets and myocytes and so on. And that then the amyloid plaque pathology induced reduction in this ratio is less evident in blood than in CSF. That is sort of the basis for why the plasma A beta test is a little bit more difficult. But then we have the fortunate situation, which is what this webinar is about, that phosphorylated tau in biofluids reflects amyloid pathology in the brain. And the simple explanation is that when amyloid plaques form in the brain, surrounding neurons will phosphorylate and secrete tau. So one could look at plasma, CSF and plasma phosphotau as a reporter of an amyloid effect on neurons. This is a little bit more complicated, and my dear colleague Kai will also discuss this a little bit further, but that's sort of a general take-home message that plasma phosphotau reflects amyloid. There are some more details to discuss here, and we will do it in this webinar. This is an autopsy study indicating this. So people donated plasma, and then when they died, they also donated their brains. We had some different sampling time points, and 8 years before post-mortem, plasma was donated, and then we could measure plasma phosphotau 181, and then you see that people is the common feature of these diseases, they have increased levels of plasma phosphotau 181 here in the blood. And other types of neurodegenerative diseases look control-like, including some tauopathies. So it really looks like phosphorylated tau in biofluids is more strongly related to amyloid than tau. But you will see some more data indicating that it could reflect both also. One way of looking at this is that you have a direct effect of amyloid on neuronal secretion of phosphorylated tau. And then these neurons are affected by amyloid, and they will degenerate and develop tangle pathology. So then I could look at the plasma phosphotau measure also as a predictive marker of tangle pathology. So direct marker of amyloid, a predictive marker of tangles. Here is one of the first assays we made in Gothenburg for plasma phosphorylated tau. And here you see frontotemporal dementia patients. They are like young adults, actually. A beta negative older adults look like this. And then as soon as there is some amyloid, there is an increase in phosphorylated tau levels. And then there is this type of stepwise increase, the more advanced the disease gets clinically. And in the rightmost part here, you see again that A beta negative groups, they are typically sort of negative for the plasma phosphotau increase. They don't have that. This has been further validated in many different cohorts using different assays. Here is again phosphotau 181. Here you see healthy control levels, MCI patients, Alzheimer patients, and then these other neurodegenerative diseases are control-like. So it looks like a relatively specific Alzheimer test. But then if you follow the tau Braak staging here, you see that the more tau pathology, the higher the level of phosphotau 181. This is what it looks like if we compare some different phosphotau forms using immunoassays. There are several phosphorylated tau forms that you can measure. And here you see 231, and then 217 and 181. They look reproducibly a little bit different from each other. So in not just this study, but in other studies, it looks like tau phosphorylated at amino acid 231 react relatively quickly to amyloid, and then it doesn't increase much more. Whereas phosphorylated tau phosphorylated at 217 has this type of increase with disease progression. And 181 comes out as it's a good biomarker, but often it ranks a little bit lower than 217 in terms of diagnostic performance. And if we compare to very good assays for plasma A beta 4240, we see that amyloid is associated with reduced A beta 4240 ratio, but the percentage decrease is small. GFAP increases a little bit in response to amyloid, it increases in response to amyloid, and NFL is a much more noisy marker in older populations. Neurofilament is then this neurodegeneration marker where you have an age-related increase. The slope of increase is higher typically if you have a neurodegenerative disease as well, but in older populations it's typically a relatively noisy marker. Here you see different phosphoforms of tau that can be measured in plasma. Here is the immunoprecipitation mass spec-based assay. Again, plasma phosphorylated tau at amino acid 181 has this type of increase with amyloid PET quartiles. 205 is a very interesting marker that is discussed a lot also, showing a similar change, and 217 increases with disease progression, whereas 231 again has this type of relatively quick increase, but not much more further. And then if we look at the relationship with tau pathology, you see a relationship, and it's pretty clear for 205 and 217. And perhaps, yeah, it's there, but not perhaps less clear also for 231. Now, if you look at the fold changes of the plasma phospho-tau concentration, you see that here you have clear changes. It's 2, 3, 4, 5-fold. So this is sort of a biomarker change that one would feel could be more easily monitored in a clinical laboratory setting than this type of small reduction in plasma beta for the 240 ratio. And I think that is why the field is moving towards the plasma phospho-tau markers. And then there is another it's a replicable thing that has been seen in many studies, and that is that phosphorylated tau at amino acid 217 often comes out at top in regards to diagnostic performance. This is just one example. All the phospho-tau markers are actually quite good, but 217 often turns out to be a little bit better than the others. And I think that is why ALZpath decided to focus on developing a really good immunoassay for 217. We have also seen this really nice study from the triad cohort and Joe Theriault and collaborators, where equivalence of plasma phospho-tau 217 to CSF in regards to detecting Alzheimer's pathology was seen. And this is, of course, extremely encouraging if one thinks about using this biomarker clinically. 5-10 years ago, we always had to think about PET and CSF. PET, of course, will give you anatomic information, which is good, but now we can see that the plasma phospho-tau measure might actually be used instead of CSF in many cases. And this is something I know Kai will discuss a lot with you also, and we can discuss it in the Q&A section as well. Here's a comparison of different biomarkers to detect amyloid pathology, and these are results from the triad and RAP cohort in a study led by Nick Ashton that was published earlier this year. And here you see the ALZpath assay with a very nice AUC to detect amyloid pathology in these two cohorts. Very similar to the CSF measures and actually tau PET as well. We have been working together with the Alzheimer's Association and the different companies and research groups that have developed phosphorylated tau assays and made a relatively big round-robin study, big in terms of the number of assays that were compared. The number of samples are just around 40. But anyhow, so here we can see that again, it looks like the phosphorylated tau, the p-tau assays that detect tau phosphorylated at amino acid 217 tend to perform a little bit better than the other assays, but this is marginal, of course. And you see then that, for example, the ALZpath assay in this direct comparison comes out as a very top performing assay. And the correlations between assays, this is CSF phospho-tau 217. You see how nice the correlations look across different assays here. So this is CSF levels, and here you see the plasma levels. Nice positive correlations. If I had zoomed in on the individual correlation plot, you would have seen that the correlation is linear, but the absolute concentrations are different. And this is a typical scenario where one in clinical chemistry could initiate a standardization project. Here are the correlation coefficients between the different phospho-tau 217 assays. And this is actually what we have done, so or are doing. So the IFCC working group on biomarkers for neurodegenerative diseases will develop or start to work to develop certified reference materials and methods for phospho-tau 217 standardization. And we are gathering in Dubai in a couple of months to discuss this further. One thing to make the biomarkers more available has been also to look at different ways of collecting this plasma. One could say that the regular venous puncture and collection of EDTA plasma is one way forward, but now it also looks like finger prick testing will work. And I think Kai will talk more about this. This is what it looks like for phospho-tau217 if one looks at finger prick test and collection of a dried plasma spot compared with regular plasma phospho-tau217 is nice correlation. The absolute concentration is different, but the correlation is there. So with this, I would like to thank you and for listening, and I would like to hand over to Kai. Thank you very much.
Thank you, Henrik. That was interesting to hear, and I will continue. There will be maybe a little bit of overlap, but I will only partly. So I will share my screen here and hope that this works now. It looks like that. So thanks to ALZpath for giving me the chance to present here today. And my title you see here, The Path to the Clinical Implementation of phospho-tau217. So it will be a little bit more clinical presentation that I will do today. Let's see here if we can change here. I just had to get this away. Yeah, I will start with a little bit of background. So these are the candidate biomarkers, both in blood and in cerebrospinal fluid we have today. So what you see here is a neuron with plaques and intracellular tangles, and then also a glial cell. And of course we have a beta 42 to 40 ratio. So this ratio compensates for the total production of A beta by using A beta 42 that you have most of in blood and in CSF. Then you have phosphorylated tau. There are some different variants that we heard about, 181, 217, 231, and a number of others actually. And we know that tau is cleaved into secreted fragments, most likely in response to amyloid aggregation and toxicity. Then we have total tau that only works in cerebrospinal fluid with a current assay. We have neurofilament light, which is more a marker for the long and myelinated axons, and we have GFAP. But I will focus a little bit on A beta and then on phosphorylated tau. So why do we actually need these biomarkers? Yeah, there has been a number of studies like this. This is when you compare a clinical diagnosis with a neuropathological diagnosis. And then even at the specialist clinic you have poor accuracy, so we need biomarkers, because otherwise there will be something like a 20 or even 30% misdiagnosis. And this is most likely even higher in the early disease stages, for example in MCI, or even more so in subjective cognitive complaints. And then we need biomarkers, especially now when we have, in the US, we have disease-modifying drugs with amyloid immunotherapies. So we need diagnostic tests to verify brain amyloidosis before the initiation of treatment. We have first-in-line tests, you could call it, for example, you can use it in primary care for triaging patients seeking medical advice for cognitive symptoms, and then maybe even in the future we could have screening tests for brain amyloidosis. So for the cerebrospinal fluid test we have FDA approved assays on fully automated instruments. I will show you a little bit about this. This is the Lumipulse instrument. So this is just some examples from our clinic in Gothenburg. This is A beta 42 to 40 ratio in CSF on the Lumipulse during 3 years. So different batches of reagents, different technicians, and completely unselected patients. More than 12,000 samples, and this is how it looks. you have a very distinct bimodal distribution of values, and you have an AUC of 0.95 even here. And if you compare that to amyloid PET, you end up this high. We also have other variants of tests, and this is the ALZpath assays. They have instead selected to use phospho-tau divided by A-beta-42, and then also total tau divided by A-beta-42, and then you end up with this type of performance, very distinct separation between groups. So you could also say that there's an almost perfect agreement between the CSF biomarkers and amyloid PET, and that you can use these two biomarker modalities interchangeably. But we need also the blood biomarkers, of course, and one real game changer, that was the Simoa assays. Ultra-sensitive tests, and most of the data Henrik showed was Simoa data. And the first assay for A-beta-42 was published in 2011. So then you could come down to really low levels of LOQ, so lower level of quantification, much lower than, for example, ELISA that we had before. This is from 2016. This is the first paper on a really large cohort for the plasma A-beta-42 ratio. What you can see here is that there is a reduction, but it's not very marked actually. So it's something like 10% drop, as we also heard before. Then if we move on, we come to mass spec techniques. This is from 2014, and it's a paper from our group publishing assays for Molditov and SRM methods for plasma A-beta-42/40 ratio. At that time we only did a small study, and you could see maybe this trend for a drop. It's not much, but there is a trend, and this has been verified quite a number of times later on in much larger studies. For example, this study here, this is quite a high number of cases, but you can see the findings are in principle the same. So there's around a 10% reduction in the ratio in amyloid positive cases in plasma, but a very big overlap, which is a problem, of course. And this has been shown also using many other assays. So compared to CSF, there's only around 10% reduction in plasma. So then, of course, you can ask yourself the question, what is the cause of this? Why isn't it larger? And maybe you have part of the explanation here, together with much other data, of course. But this is a Simoa study on the correlation between CSF and plasma A-beta-42 in this case, and you can see that there's no correlation at all. And this is just to show that this is not method dependent. So this is immunoprecipitation mass spec data on A-beta-42 and 40, the correlation between CSF and plasma, and there is no correlation. That's the problem. So this is a biomarker problem and not an assay problem, and the problem is that this biomarker doesn't come from the brain more than just a little bit. And as Henrik showed, this minor change is overruled by the massive overlap. And it works in research studies, because there you have you evaluate the biomarker performance in single studies, and you analyze all the samples in one batch under optimal conditions, and then you identify the best cutoff and calculate your AUC and present this. And that often ends up quite high. But in clinical routine, you have to do the other way around. and then you have to set your cutoff, and then you have to have a biomarker assay that is stable enough to withstand not only the analytical variations but also bias across reagents and biological variability and so on. You see it here that the accuracy will depend on many things as listed here. And then as soon as you start to, you have some variability, as was tested in this study. So this is a simulation of increasing analytical CV. And then you see that a beta ratio, even if you do it by IPMS, it drops very quickly. And rather soon you don't have a good biomarker anymore. Other things that can affect plasma A beta is drug treatment. So one commonly used drug, it's estimated that more than 1 million people in US are on this drug. So this is Entresto sacubitril, which is a neprilysin inhibitor. And these are data from a 1-year clinical trial called the RECOVER study. And here you see if you inhibit neprilysin, then a beta ratio drops. It drops by 30%, which is much more than the drop you see by brain amyloidosis and AD. So this is of course a major problem, that this interference will induce a risk of misclassification, of course. So we need more biomarkers, and the success story really has been phospho-tau. Henrik shows this briefly. Also, you have different assays. This came around 2020 or something like that. So phospho-tau 181 by MSD, and our Simoa method. Here is an MSD 217 method developed by Lilly. Here you see 231 from Gothenburg, and they all perform rather similarly, at least. So they are increased in AD, also rather early in this disease. You see clear associations with amyloid PET and tau PET, and phospho-tau is normal in other dementias. There has also been a number of studies comparing these biomarkers, so 181 versus 217 versus 231, and so on. And it looks a bit like this, that 231 seems to react a bit earlier than 217 on amyloid pathology, but with time 217 catches up and increases more and more, both in unimpaired and in MCI cases, and seems to better track disease progression with a higher fold change. So here is again the round robin study. I would like to show this. This is the correlations again against 217 assays in plasma, and it's really good correlations across the immunoassays, and also between the immunoassays and the IPMS MOSPEC method that was included in this round robin study. So both for 217 by IPMS and the phospho to non-phospho 217 ratio correlations are high with the immunoassays. So maybe it will be like this in the, or on the path to the clinical implementation, as my title is, that the choice of method will depend on factors such as need of automation and accessibility of assays, and of course the cost per test for the assay. So let's move on from here. I would like to show this study again. This is a little bit different. This is the ALZpath assay for 217, and this is in 3 large cohorts, really, so 300 to 200 patients, and the performance is very good across these different cohorts with very high AUCs to detect amyloid positivity by PET, tau positivity by PET, and to differ between these patients. So really high clinical performance and promise for a clinical assay for phospho-tau 217. But I will also show you some data in relation to neuropathology. So this is from the Life Molecular Imaging cohort. It's a study with Norman Coughlin in Germany and Michael Scholl in Gothenburg. So it's more than 200 near end-of-life subjects with AD, other dementias, and also non-demented. So there you have not only amyloid PET but also neuropathology to compare with the plasma biomarkers. And here you have CRAD scores for amyloid, so high versus low, and you can see that the AUCs end up really high, so 0.92 in this study. And here you have the same thing for Braak stages for tau pathology, and with again really high AUC value. So again, very good performance. So one thing also on the path to the clinical implementation is how early can we go with phospho 217 assays. So this is just a quick overview of some studies. Actually, I think the findings are very similar in all studies, that you have a clear association between higher phospho-tau levels 217 and others, with higher Tangle scores post-mortem, with higher tau pathology measured by PET, with higher clinical stage, and that for 217 phospho-tau increases with time and becomes more clearly positive. So maybe if we want to go early on, we need other types of algorithm for probability score instead. Something like was proposed in this study. So this is plasma phospho-tau 217. Again, this is another assay. I think this one is the Lilly assay to predict A-beta PET positivity. And here you see the data using one cutoff. The usual way, you end up with quite high AUCs. They are 89% and 94%. But in clinical routine, you have to consider also what does this mean, AUC. We don't really use AUC values in clinical chemistry. So instead you need to consider things like false positive rates and false negative rates. So in these two biofunder studies, the false positive rates were 18 and 17%. And this is maybe a little bit high. Is this acceptable if you want to use this as a single test and initiate treatment with disease-modifying drugs? So maybe an option is that you do like this. This is the two cutoff principle. So you can identify high-risk patients, and then you can have low percentage of false positive, low risk patients, and again low false negatives, and then you are left with a group of intermediate risk. And maybe it can look like this in the future clinical routine, that you can identify patients with high probability, you can make a clinical diagnosis in some cases, or you can admit them to the specialist clinic for disease-modifying therapies. You can clearly rule out AD, but of course you need to think about what other causes there are for the symptoms by other biomarker techniques. And then you have an intermediate group where you need maybe to do a PET scan or a CSF test. One good thing is also that these biomarkers seems to work in the clinical trials to monitor treatments, and this is from the lecanemab phase 3 trial. The A-beta protofibril antibody, you see that phospho-tau 181 in this case drops from month 6 and on, and this is from the donanemab trial, where you see a reduction down to 23% of baseline levels in the patients, the AD and MCI patients, from week 12 and on. So maybe we can use phospho-tau in plasma like this to try to understand how long we need to treat, or if phospho-tau 217 will creep back up when you discontinue treatment and need to start it up again, and that type of questions. One thing, of course, if we want to use plasma phospho-tau to monitor treatments, is the biological variability. So how much is the variation in healthy people, for example? This is a study on this by Wagner Brum. This is 20 healthy younger people, so 40 to 60 years, if that is young enough. So blood samples weekly for 10 weeks, and here you see the analytical variability and the within subject variation. So for 217, for example, it's around 10%, with an analytical variability of 5%, which is quite good. One thing you see across the studies, also speaking about variability, is what you could call random flyers. And what could you mean by that? This is patients who are amyloid negative but still have rather high values of phospho-tau 217 in this case, so in the same range as the AD dementia patients actually. So I think we need to learn a little bit more. This is again from the biological variation study. You have one subject here on top, so for both 181 and 217 the levels are quite stable, but for another person then you see that at week 6 and week 10 levels go up, and this is for both 181 and 217. And note that the other blood biomarkers, they were really stable in these two individuals. So maybe we need to learn a little bit more on pathophysiological factors that can influence the blood biomarkers. Maybe we can look a little bit on what has been done for the CSF tests, and especially for A-beta-42 in the standardization procedure by the IFCC, International Federation of Clinical Chemistry working group. And there we today have reference measurement procedure. This is a gold standard method for A-beta-42, approved also by the Joint Committee for Traceability in Laboratory Medicine. We have certified reference materials at 3 different levels, so they are available by the European Commission Joint Research Center in Belgium. We have validated high precision methods, and we have studies showing alignment of the assays, so that the different assays actually give the same readout in concentration. So this is the completed standardization of CSF A-beta-42, and I think we need, ideally at least, the same for the blood biomarkers, and this is already ongoing. We also need further studies, I think, at least, especially prospective and consecutive studies in real-life patient cohorts at memory clinics or in primary care, where you have preset cutoffs and samples analyzed in a fashion the same as you do in clinical routine. I think we need a little bit more data on possible differences related to, for example, ethnicity, clinical stage, as I talked about, mixed pathologies, what that will do, medication. We heard about the A-beta ratio and sacubitril, and probably much more. And I think that in the end, when we have analytically and clinically well validated assays, and we are well on the way, I would say, but also when for assays that have prices that are substantially lower than costs for the PET scans, then this will make the blood biomarkers attractive complements or even substitutes for PET imaging and CSF tests. Thank you so much.
So first of all, thank you very much, Dr. Sitterberg and Dr. Blino, for a great presentation. As Andreas was mentioning, we do have some questions to come up. Please, if the audience have more questions, to keep submitting it to the Q&A bottom, please.
Well, thank you. And just as a way of brief introduction, I'm Andreas Jeroman, Chief Scientific Officer to ALZpath Incorporated. Again, thank you for participation and obviously the two speakers. So I try to group the questions because they center around, I think, 2 or 3 themes here. One, maybe if Kai would like to start, is what are the challenges for IPMS, so immunoprecipitation coupled with mass spectrometry for p-tau? I assume that refers specifically to plasma or blood.
Yeah, I think the data looks really great in the IPMS studies. I think there are some questions, more scientific questions, that are being examined in different studies, and the results vary a bit across cohorts. So, for example, is there or is there not any difference between phospho-tau 217 by itself, or if you make a ratio with a total tau or a peptide from total tau, you could say it's called, I think, 212 to 221 non-phosphorylated, so p-tau 217 to t-tau 217 ratio. So the problem maybe there is that you actually introduce a neurodegeneration biomarker in the form of total tau, and whether that's good or bad, I think we need more studies on this. Some studies say that it doesn't make much of a difference, and others studies say that maybe the ratio is doing a little bit of standardization work here, but I think the future will tell more. And as we heard also that these mass spec methods, they correlate very well with the immunoassays, so that's very positive, of course.
So related to this, maybe to the method developed in Gothenburg as well to capture the analyte or p-tau specifically, is the setup to use a phospho-tau specific antibody as a capture antibody or total tau? How is this done, if you can disclose?
Sure. I mean, it's published in several papers, so it's not one, but I think it's 3 different non-phosphorus, so total tau antibodies to capture all variants. And then you can measure different phosphoepitopes. You can, as Henrik said, you can measure the brain-specific variant of total tau, and you can measure the non-brain specific variants, for example, this 212 to 221 peptide that matches the phospho 217 peptide. So yeah.
Very good. And then maybe the final in this sort of domain of technical, if at least IPMS related, is there an impact on phosphorylation at 212 on analyzing 217? I think that question potentially relates to what we've seen with some of the immunoassays, no? Where binding to 217 seems to be influenced by 212, 217.
Yeah.
Is there an impact in mass spectrometry?
In aspects. I would say no, but I suggest that we move on to immunoassays because that's the topic, so that we don't get stuck into mass spec discussions.
And for the round robin, the next question is, in the comparison or round robin studies, were the antibodies the same? I guess the answer to the question is that's exactly the challenge, but I don't know, maybe Henrik, you want to elaborate on this? In the sandwich, what's different?
Exactly. I mean, there are different antibodies in different sandwiches. We still saw good correlations. There are also potential differences in the calibrators across assays, but the nice linear correlations, I mean, they are super nice, basically. So that really indicates that the standardization project will work here.
Well, maybe I can comment, Andreas. I think it's important to stress that a round-robin study or a commutability study the aim is not to compare assays, so their diagnostic performance or anything like that. It's the first test or the first study where you can compare correlations across assays, so that they in round-robin studies correlate, so that you know that they measure the same thing, the same variant of a protein, and in commutability the aim is to identify the best future calibrator for the certified reference material.
Just to follow up on this, so just to the last biological variability study as well, the comment here is, do we need multiplex assays? I don't think necessarily was the implication, but specifically the question pertains to the pre-analytical stability. So in the biological variability study by Wagner-Brooms, all the samples were processed in the same way, so that as a variable was eliminated, if I understood and remember it correctly as a co-author. That's one. And based on pre-analytical stability data you and others will publish for p-tau217, that's probably one of the most stable biomarkers in terms of freeze-thaw cycles, sitting at ambient temperature, and others, the remote testing or blood collection you presented. Would you agree with that? Or so pre-analytical variability or variation is really not a reason for the you called them the random flyers in the biological variability study.
No, exactly. It must be something more biological, but to be honest, I have no clue why we can see this.
I could also say that if there might be some slight diurnal variation, but if you compare that to the Alzheimer pathology induced fold change in the biomarker, that is minor. So it's like that's why we think that phospho-tau217 and the other phospho-tau forms are so promising as clinical markers, because if there are small variations which we often see for clinical chemistry tests in relation to food intake, diurnal variation, or some other potentials like confounders, this 2, 3, 4, 5-fold increase might not it might not matter that much.
Mm-hmm.
Great. So then kind of changing gears a little bit and talking about where we are on the roadmap for clinical implementation, there's a number of questions. I mean, I would say the ALZpath, the X, which is the ALZpath p-tau217 assay, is actually available for clinical practice with the partner lab, which is NeuroCode in the state of Washington. And we have established reference intervals, so have others. But the question here, and that is pertinent to this, is does p-tau217 vary significantly in concentration across healthy people? Cognitively unimpaired maybe is implied here, but it refers to healthy people. So maybe can you, in your data and your analysis, is p-tau217, is it age dependent? Is there an influence of sex, gender? Is this a fairly robust biomarker in the age relevant group of 50 to 85, for example? Could you comment on this? Unlike NFL, which is age dependent.
Absolutely, yeah, it's much more robustly associated with Alzheimer's pathology, and there might be a slight age effect, but that could be because of increased prevalence of age-related Alzheimer's pathology. So it's much less problematic from that standpoint compared with NFL.
Yeah. And then related to this, so if we had to, have a crystal ball today and make a decision today, right this minute here, as today, which tau isoforms are the most promising of making it into clinical practice? I alluded to ALZpath DX, the other versions as well. I mean, would we agree? Maybe discussion p-tau217, and was the title of one of your slides, is currently considered in terms of diagnostic accuracy the top performing biomarker in a number of independent studies across platforms. Is to you that the status of clinical evidence?
Yeah, I agree on that. Yes.
So, I mean, if we think about what are we missing? I think you alluded on the last slide. We obviously always need more data. One can never have enough clinical data across diverse ethnic groups. Do we currently don't have an FDA-approved platform. Do we need an FDA-approved platform to move that into clinical practice? Because it comes with different timelines.
Yeah. Maybe I can start. There's something called a laboratory developed test, and that is what, for example, is used a lot in Europe, or at least in Sweden, and I'm sure it's used in the US as well. That is without, so to say, FDA approval. Still, you will have a very high quality demands, and you can do that in an accredited laboratory. You can be part of proficiency programs. You can do a full validation of the assay in your laboratory, and you can have really high quality cutoff levels, either 2, as I proposed, or 1, depending on what type of application you aim for. So I think it's no problem to start with this type of assay in clinical routine right away, as soon as you have done these parts, of course, but without any more general approval by FDA or so.
I agree.
Did you want to comment on it?
No, I agree. I think it's time to move fast now because of the situation now, also with the treatments. So it's we need to get this sorted as clinical chemistry laboratories, and that's nice also that we have all these interactions that we have had in the CSF biomarker community with the Alzheimer Association QC program and such things that could now be expanded towards so that we can meet the demand of external quality control in this field.
Yeah. So then there's more a comment of a question in the ALZpath method, superior method of testing for AD, and I think you showed data from the Ashton paper, Nick Ashton's paper, that in plasma the ALZpath p-tau217 appears equivalent to CSF. Is this the answer we would be giving here?
Yeah.
Compared to CSF p-240, and it has a high diagnostic accuracy when compared to amyloid and tau PET. That was the takeaway from Nick Ashton's paper in JAMA Neurology published recently, wasn't it?
Exactly.
Okay. So I need to so I apologize I will not be able to answer all the questions. We will post meeting here, as Zoom will end this very quickly here, but I think also related to clinical implementation, understanding not just comorbidity. This is a comment related to higher physical activity, where there are published data of relationship to plasma 4240 amyloid burden, however this is measured. How important we think that is really in clinical practice, where we're not fasting necessarily, become different hours of the day, different degrees of sleep. What do we think in clinical routine, truly routine, are the most important parameters?
I think the paper, I mean the room paper with those flyers, that we need to figure out what's happening there. That's for sure. And I do not. Were there any clues, Kai, in Wagner's study? No, that's.
There wasn't. But I mean, it was clear, as Andreas said, that it's likely not. It's not one assay, because it was 2 different assays. It's not the general degradation of the biomarkers in the sample, because the other assays were stable, including Aβ42. So it must be something related to phosphorylation status of tau.
Very good. And then a question to the importance of comparing timing of changes in plasma p-tau217 to changes in amyloid PET CSF p-tau. I mean, I think generally we agree we do need to compare the longitudinal measurements of importance to determine disease onset and at what stage of the disease we start seeing changes in p-tau217. I think you alluded to this when you compared it to 231, if I remember this correctly. I don't know if you want to comment on this. I mean, the challenge with so-called sporadic AD is that we don't really exactly know when the disease onset is. Now it's a calculated disease onset, unlike the familiar form of Alzheimer's disease.
It's a very interesting topic, because if one knows that you have sporadic Alzheimer's disease in the family, for example, one could think about starting to monitor this biomarker, and when you're 50, 55, 60. And then one could also ask, when is perhaps the first sign is a change in the biomarker rather than crossing a certain cut point. But that we don't know yet. And that will be an interesting topic for future research. What is the first pathology indicating change in intra-individual phospho-tau measurements or concentrations?
Yeah. So I think maybe two more, if we can here, or one more after this question. I see a comment in the chat room, which is more as to other p-tau assays here, not necessarily 217, 231, 181. There's obviously data emerging 202, 204, 205, pardon me, MTB, R tau 246. Where do they fit in the tau toolbox? Is it earlier than 217 data to be developed? Do we know currently?
I think we need more data there as well. There are some variants of MTBR tau biomarkers. So one variant is called tau 368. That is from the MTBR domain number 4. And then we have this 243, I think it is, which is from the MTBR domain 1 instead. So I think we have to learn more about the performance of these MTBR variants of tau biomarkers.
Very good. Unfortunately, we're out of time, but we'll answer the question at post-meeting and obviously send a link to the recording as well. I want to thank Henrik and Kai Samba Science for arranging for the webinar, all the participants. I know we didn't get to all the answers, but we will do so after this webinar. Thank you again.
Thank you.
Thank you.
Absolutely. Thank you very much, Andreas, for that closing and moderating the questions. As Andreas said, ALZpath will get back to you with answers to any unanswered question. Also, if you have any additional question, you can visit alzpath.bio to learn more. And as a reminder, this webinar was recorded. So in a few days, we will reach out when this webinar is recording and available on demand. So you can please share it with your friends and colleagues and anyone who think you will be interested on it. So again, thank you very much, Dr. Siderberg, Dr. Blenov, and we thank all you for attending today. Please take care and goodbye.